to discuss something which is basically the heart of multivitamins. Okay, this is basically the heart and core of multivitamins. This is where it's supposed to actually make sense. Okay, that is B6 and B12. They go hand in hand. They play an essential role across all spheres of metabolism: lipid metabolism, carbohydrate metabolism, synthesis reactions, transamination, deamination, okay, and especially neurotransmitter formation with special emphasis on folate trap. Okay, this folate trap is asked multiple times through various spheres. Clear? So, without talking a little bit about B6, I cannot talk about B12. So, let us delve into it. We need to know the general biochemistry, the function and the deficiency. What the most important thing about vitamin B complex is, it is not at all stored in the body, especially B6. B12 might have minor stores in the liver, otherwise it has to be continuously supplied by the diet. It has to be continuously supplied by the diet, and it will be excreted out of the body any excess amount that you get. So, there is essentially no storage. For every day-to-day use of your enzymes, you need a constant supply of vitamin B complexes. So, what they do? Okay, important for growth and good health. Good health of what? Good health of your enzymes. Okay, take part in various biochemical processes, that is, they act as cofactors and functions as coenzymes. There are three forms. Okay, we all know pyridoxine, pyridoxal and pyridoxalamine. All of them will be converted into PLP, that is pyridoxal phosphate, which is the active form. Okay, all three of them will become pyridoxal phosphate, which is the active form. See, this is the structure. It has a pyridoxal ring. Okay, so it has a pyridoxal ring. It is just for you to see. We do not expect you to know the structure and remember it. Neither do I. It's a very difficult job. What are its functions? This is where it becomes important. Transamination, deamination, decarboxylation and condensation reactions. Okay. In enzymes, I do not know whether you were taught ping pong metabolism or generation of Schiff's base. Okay, it's a transient state in which pyridoxal phosphate holds one amino acid and one keto acid in two hands and interchanges them. Okay, so that is called ping pong metabolism. It's a very nice thing to know, not required at your level. If you are interested, then do please check the internet or come to us. We will show you how the Schiff's base works, but you have to know what Schiff's base is. It's a transient state of the enzyme. Okay, it's a transient state, the active form in which the enzyme is particularly holding the two groups and interchanging it. Okay, so that is transamination. Deamination, you know, examination of example of deamination. Example of deamination: amide group is being removed. Enzyme name glutamate dehydrogenase. Okay, there also vitamin B6 is necessary. Okay, decarboxylation. Have you heard of histidine? Histidine? Yes, you have heard of histidine. I am so proud of you. Tell me, what is so special about histidine? Something special, very special about histidine. No, it is a dibasic monocarboxylic amino acid. That means it is a what kind of amino acid? I cannot hear you. I am a little short of hearing. Yeah, what? If it has two amino group, what kind of amino acid it becomes? Your friend wants to say, she wants to answer your question. You want to pass it on to her? Or you don't want to pass? You want to pass? Of course, if there are two amino groups, it is going to be a basic amino acid. And basic amino acid helps in what? Helps in what? Yes, madam. Basic amino acid plays a crucial role in what? pH of the body. Okay, pH of the body. So then, that is why from histidine you get histamine via histidine decarboxylase. The carbon dioxide is shifted out and you get histamine. Why is histamine important? It plays role in what? Allergic reaction. Exactly. It plays a major role in allergic reaction. Okay. There is vasodilation, increased vascular permeability and transmission of cells, WBCs from your circulation to outside. Okay. So let's see it in little detail. First of all, synthesis reaction, ALA synthesis. Regulatory step for what? I am the poor soul that took this class. Heme synthesis, exactly, thank you. At least someone remembers. Heme synthesis, first step of heme synthesis, okay. ALA synthase. This is the first condensation reaction where PLP plays a major role. Then you get decarboxylation reaction, okay. At first you have tyrosine, then you have tyrosine hydroxylase, and tyrosine hydroxylase will give you DOPA, and here comes your vitamin B7 or vitamin H or biotin. I will be taking that also today only. Biotin, the active form of biotin is tetrahydrobiopterin. See, tetrahydrobiopterin. It is being used as a reducing equivalent. It is not a reducing equivalent, it is being utilized as a reducing equivalent. Okay. And then you have dihydroxyphenylalanine, DOPA. And once you decarboxylate it, you shift the carbon dioxide out of it, you get dopamine. Okay. You get dopamine. Then again, if you hydroxylate it, you get norepinephrine. Again, if you decarboxylate it, you get an epinephrine. So across all around the neurotransmitters, all are being synthesized by PLP as a coenzyme to these reactions. Of your major neurotransmitters from dopamine to norepinephrine to epinephrine, all are being synthesized by PLP. Okay, it plays a major role in your neurotransmitter synthesis. Okay, as I have already told you, histamine got decarboxylated, histidine got decarboxylated to get histamine. Another series, serotonin coming from tryptophan. Okay, serotonin, another neurotransmitter that is being formed by decarboxylation reaction, and the coenzyme again is PLP, pyridoxal phosphate. Transamination reaction already covered, dehydrogenation reaction already covered. Okay. Now deficiency disorders of vitamin B6, and the answer is deficiency disorder of vitamin B6 causes what? Some kind of anemia, megaloblastic anemia. Very good. Vitamin B6 causes megaloblastic anemia. Okay. Dietary deficiency is rare, but it is found in primarily old age, newborn infants, women on oral contraceptive pills, alcoholics, okay, and isoniazid treatment. Isoniazid is being given to what patients? Tuberculosis patients, okay. And what they do is, isoniazid basically takes off the folate away from the bacteria so that it cannot synthesize your DNA. Bacterial DNA cannot be synthesized. That is how isoniazide works. Okay. So, what happens is during isoniazide treatment, our vitamin B6 stores also get decreased, and that appears as peripheral neuritis, tingling neuralgia. Okay, tingling neuralgia, severe neuralgic pain. Okay, this is how it appears. See, deficient amino acid metabolism, deficient lipid metabolism. Okay, this deficient lipid metabolism is due to absence of inactivity of methyl malonyl mutase enzyme. This methyl malonyl mutase enzyme plays a major role in your lipid chemistry, and it helps utilization and formation of proper fatty acids. And these fatty acids and lipids are being utilized as insulators for your nerves. They are primarily being utilized as insulators for your nerve. Since they are being utilized with that, if you have a vitamin B6 deficiency, that entire nerve supply will become, and that is why you are having neuralgia. PLP is involved in the synthesis of sphingolipids. Can you name some? Sphingomyelin. Very good. That's a physiology answer. I am looking for a biochemical answer, biochemistry answer. Only one answer, sphingomyelin, that's all. Yet sphingolipid storage disorders are one of the major crux of questions that are being asked in your All India. Anyway, either you will read it now or you will read it later, but you have to read it anyways. So, no essence. Mild deficiency leads to irritability, fluctuation of mood and depression. Severe deficiency leads to peripheral neuropathy and convulsions. Okay, this is the spectrum of signs and symptoms that you actually get in vitamin B6 deficiency. Now let us look into vitamin B12. Okay, so vitamin B12, the active form is cobalamin. Okay, the active form is cobalamin, and there are two active forms. First is cyanocobalamin. That means the cyanide is embedded in the middle of the ring, just like iron was embedded in tetrahydropyrrole ring. Okay, like iron was embedded in myoglobin, like copper was embedded. Another sleeping beauty. Please leave. No, you don't want to listen. Leave, please. You don't want to listen, leave. No, you have given your attendance. No. Cyanocobalamin, hydroxycobalamin, S-adenosyl cobalamin, and methylcobalamin. All of these are the active forms of vitamin B12. Okay, and there is no storage form. Very little of it can be stored in the liver. Otherwise, it is free. It is coming in your body and going out. Adenosylcobalamin and methylcobalamin are utilized as coenzymes for different reactions. See, this is the chlorine ring. This 1, 2, 3, 4, 5. This pentagon ring is called chlorine ring. You had a tetrahydropyrrole in hemoglobin. Here you have tetrachlorine ring with a cyanide. This is how the structure actually looks like. Essential for normal nervous system function and red cell maturation. Okay, just before RBCs, the previous stage is reticulocyte, right? From reticulocyte to RBCs, here you need maturation factors like B12 and B6. This allows complete formation of the RBC and extrusion of the nucleus so that the reticulocyte can become RBC. In its absence, the nuclear material remains and the entire cell swells up to form a big cell. And you know RBC is very small. Why RBC is small? Because it needs to go through the fine capillary system. Okay, it has to go through the fine capillary system. So if it grows large, if it grows big, then it will be caught by your reticuloendothelial system and it will be taken out. That is how megaloblastic anemia operates. Okay, all of these are maturity factors for RBCs. Here is another concept, very important concept, and that is Cassell's intrinsic factor. Cassell's intrinsic factor. This Cassell's intrinsic factor is being secreted from the parietal cells in gastric epithelium, and the parietal cells basically secrete hydrochloric acid. Is your hydrochloric acid useful? Can you tell me why your hydrochloric acid is useful in your stomach?
So pepsinogen.
Yeah, pepsinogen, okay. How much portion of protein digestion is done by pepsinogen? 2%. Why are you interested in 2%? I want to talk about the 98%. So, HCl and activation of pepsinogen is a very small thing in respect to the bigger picture. Okay? It's a very small thing. So, what is the biggest role? Maintaining pH? No. Yeah, exactly. It is innate immunity. It is innate immunity. It is destroying all the bacteria that is entering your gut through your mouth. That is why you can have 20 episodes of Fuchka beans and get sick only once. So praise your hydrochloric acid. Okay, that same cell that was secreting the hydrochloric acid, that cell only is secreting this Cassell's intrinsic factor. And what is this Cassell's intrinsic factor? It is a smuggler. It's a smuggler. It's a smuggler for what? Exactly, it is a smuggler for B12, because B12 only comes from animal protein. Animal protein is a foreign protein to your system. It will not be that readily absorbed. Okay, that is why we have this intrinsic factor who will smuggle that protein from your gut lumen into the cell, and this happens in ileum. This happens in ileum. Okay. Now think, so many things can go wrong there. What can go wrong? Tell me a few causes that you can think of that a person's ileum is short. The easiest answer is adenocarcinoma stomach, squamous cell carcinoma stomach. Okay. So there we have to do a gastric pull-up operation. We have to remove that part of ileum. Think of Whipple's procedure in surgery, where there is a CA head of pancreas, your ileum is being removed. That is the easiest thing that students can think of. What are the better answers? Type 1 anxiety, a type 1 anxious personality, popping pills, proton pump inhibitors, like they are going out of style. Popping pills 2 to 3 times a day. No hydrochloric acid. All parietal cells are suppressed. No Cassell's intrinsic factor. No Cassell's intrinsic factor. And you land up with a megaloblastic anemia. Okay. You will end up with a megaloblastic anemia. So these things are very common. And it is actually very difficult to clinically decide whether this person is having an anemic change, whether this entire thing is just organic, it is just something in the patient's mind, whether there is actually a deficiency, or whether there is actually something wrong with the neurotransmitters. And again, you need vitamin B6 and B12 for those neurotransmitters. So to reach a clinical decision in these cases is very difficult, especially if you are going to see more than 200 patients per day. Especially if you are going to see more than 200 patients per day, and that what all of us will end up doing. Okay. But still, a thinking doctor is a good doctor. See, B12, Cassell's intrinsic factor, binds, taken in through your ileum into your blood from the gastric lumen. See, vitamin B12 deficiency is observed in patients with intrinsic factor deficiency due to autoimmunity or by partial and total gastrectomy. So, where this autoimmunity come from? You will learn later down the line. In your PSM, you will learn first diseases that are called malabsorption syndrome. Diseases that are malabsorption syndrome, like celiac disease, tropical sprue. Okay, all these disease, what happens is there is gluten sensitive enteropathy. What happens is your intestinal lining becomes flat. Your intestinal lining is actually corrugated. It's just like a corrugated rubber sheet. Why it is like a corrugated rubber sheet? In order to increase the surface area for absorption of food. Okay, due to this, it becomes plain. So there is a major loss of sites of absorption. So if for a normal person the absorption rate was 90%, in these cases it is 30% or 50%. So in these malabsorption disorders, which are basically autoimmune disorders, you will find deficiency of vitamin B12. Okay. See, fatty acids, methylmalonyl-CoA mutase, and here you are using SMA and SH to methylate it to succinyl-CoA, and this succinyl-CoA is the prime of AC molecule which will drive your lipid synthesis. Okay. Conversion of methylmalonyl-CoA to succinyl-CoA. Okay. This enzyme in this pathway, methylmalonyl-CoA mutase, requires vitamin B12 as a coenzyme. And this is the most important part. From homocysteine to methionine. Conversion of homocysteine to methionine is the most important part, the prima facie enzyme being methionine synthase. And look at the cofactor over here, methylcobalamin. Methylcobalamin. So, in order to run this reaction, this N5-methyl tetrahydrofolate has to become dihydrofolate. Okay, this tetrahydrofolate will become dihydrofolate. So now just think, if there is absence of vitamin B12 in the body, you are getting what? Homocysteinuria. You are getting homocysteinuria, and we know that homocysteine levels play a high role in cardiac events. Okay, high levels of homocysteine have been seen in ischemic heart diseases. So that is a major role. Now, this N5 tetrahydrofolate has become tetrahydrofolate. It has become tetrahydrofolate. It has given its methyl group. Now you have got PHFA. But in order to continuously run this reaction, what do you need to do is, you have to convert tetrahydrofolate to N5-methyl hydrofolate. That is being done by one carbon metabolism. And the methyl donor here is SAM, S-adenosyl methyl cobalamin to SAH. And that reaction is being run by folate. So what happens is, if this vitamin B12 amount goes down, if your vitamin B12 amount goes down, then finally there is no homocysteine to methionine, and your N5-methyl tetrahydrofolate is getting stuck. This N5-methyl tetrahydrofolate is getting stuck. Basically, your folate acid is getting stuck in this form, N5-methyl tetrahydrofolate. There are so many forms like that. There is N5-N10-methyl tetrahydrofolate. There is N5-methylene tetrahydrofolate. They are also being utilized to run lots of reactions. So with decrease of your vitamin B12 levels, your vitamin B6 levels will get stuck, and you will not get sufficient folic acid to run other metabolisms. This condition is known as folate trap. I will show you a little better way. And in vitamin B12 deficiency, what happens is, if there is Cassell's intrinsic factor deficiency, then only you call it what? Anemia, pernicious anemia. Otherwise, you call it megaloblastic anemia. Do not confuse between the two entities. Pernicious anemia is also a megaloblastic anemia, but the cause for pernicious anemia is not absence of vitamin B12 in diet. It is due to suppression of Cassell's intrinsic factor secretion. So do not confuse between the two. So if you say pernicious anemia is being caused by vitamin B12 deficiency, that's a wrong answer, and you will be penalized, and the examiners will ask you this question so that you can make that mistake. Once you make that mistake, they will catch hold of you there, and they will drag you straight to one carbon metabolism. From there, they will drag you to folate trap. From there, they will drag you to amino acid metabolism, serotonin metabolism, which questions are actually very difficult to answer in the Viva. So for God's sake, please answer folate trap and please answer pernicious anemia correctly. It is going to save you a lot of headache. See, wait over here. Tetrahydrofolate, there is N10-formyl TH, N5-N10-formyl TH and methionine TH, methylene TH. Which one selected? Homocysteine remethylation reaction. We were reading methionine to homocysteine, right? Homocysteine to methionine. Now think of the other way around. Homocysteine remethylation reaction is the only pathway where N5-methyl THFA can be returned back to THFA pool. Okay? And if this happens, if it gets stuck in this metabolic loop, then there is folic acid deficiency, which is entirely necessary for purine and pyrimidine synthesis. This is how the entire mechanism is working. Okay, so megaloblastic anemia, vitamin B12 deficiency. Okay. Another very important thing which occurs is combined degeneration of spinal cord. Okay, combined degeneration of spinal cord, where your anterior and lateral spinothalamic tracts are getting involved. So what you get is severe neuralgia and flaccid paralysis. You get a flaccid paralysis in case of vitamin B12 deficiency. Okay. Now here there is another thing. You have got a combined degeneration of spinal cord. Very good. You know it is folate deficiency. You know it is vitamin B12. You give plenty of vitamin B12. Next day, the condition of the patient become more worsened. Why? So much vitamin B12 drove that reaction so much that all your folic acid were being stuck as N5-THFA. So whenever in this case, if you are lucky enough to see a severe combined degeneration of spinal cord, please supplement both folate and vitamin B12. If you will supplement only vitamin B12, then the condition of the patient will worsen. And that is how folate trap actually operates in your day-to-day case history and in patients. See, myelin sheath of neurons, chemical damaged. Which path? Methylmalonyl CoA mutase. Formation of methylmalonyl CoA to succinyl CoA. Neuropathy. Okay, because there is bad insulation across all nerves. So you will have tingling and severe pain. Paresthesia is abnormal sensation, reduction of perception of vibration and position. This is the principle of posterior anatomy, posterior tract, posterior spinothalamic tract. Okay, this is the hallmark. They take up the position sense, vibration. Okay, that is the hallmark of your posterior tract. Absence of reflexes, flaccid paralysis, obviously you will get absence of reflexes. Psychiatric symptoms, you will get low mood, you might get seizures, confusion and memory loss, depression, unstable mood. See, if I cannot operate this by hand, it is literally useless to take the class like this. I don't know what you people are doing. If I have to give you a cue each and every time I want to change the slide, when will I give you the cue and when I will teach them? Please show that vitamin B7 biotin slide. The thing that is left for the discussion is biotin. Okay, we are short of time also. So today I will not be discussing biotin. We will start with other metals, either calcium or magnesium, I don't know, whatever HOD sir will decide, we will take that class, and before that I will discuss biotin, because in this slide you will not be able to understand.
Metabolic syndrome, yes, metabolic syndrome, obesity, insulin resistance, hyperinsulinemia, all are very important, and any topic it comes from this, any terms or anything you can write without any memorizations, right? So, and the last topic was the sleep cycle. Right, that is very important. Melatonin, sleep cycle, relations, and tell me some names. AJ, you green. Tell me some names of antioxidant. Ekdom bose bol. Name 2 or 3 antioxidant. Ki bol? Vitamin C, number 1. Or last bench, you. Ball. Name of antioxidant. Danish na. Oh, ye last bench. Hey je. Tui. Chola ekhane samne. Come. দেখি তোদের হালচালটা একবার দেখো জায়গায় বস বল তুই বল তুই জল খাচ্ছিস বল অ্যান্টিঅক্সিডেন্ট নেম। নাম্বার 1 ভিটামিন ই, নাম্বার 2 হ্যাঁ কি বিটা ক্যারোটিন, নো, আর বল হ্যাঁ ক্যারোটিনয়েডস, ওকে মানলাম, লো ক্যাটাগরি। এনিথিং এনিথিং আর গ্লুটাথায়োন। So vitamin E, glutathione, vitamin C, melatonin, these are the antioxidant. বুঝতে পারছিস ভাইবা গুলো কিভাবে হয়? বুঝতে পার ভাইবা যদি যেই তুই ফার্স্ট কোশ্চেনটা পারলি না, then your impression will be in lower grade. তোকে আরো শর্ট কোশ্চেন মানে করা হবে, তাও পারলি না, এবার তুই ফেলে ঢুকে গেলি। So very very careful. This year will be very tough exam for you. Be assured that যে তৈরি করে আসছিস। যারা ভাবছি যে মোটামুটি কোনো ব্যাপার না, হয়ে যাবে, হবে না। দিস টাইম উইল নট অ্যালাউ। পড়াশোনা করছিস না কে কে বল? সবাই করছিস? ওকে, ফাংশনস অফ ইনসুলিন বল। এই যে তুই বল, একদম ঘুরে আছিস দেখিস। Functions of insulin hormone. Yes, blood glucose কমিয়ে দেবে, বেশ, নাম্বার 1। নাম্বার 2 ওকে, দেন তুই একটা বল, জানিস না, তুই একটা বল। লাস্ট বেঞ্চ, রেড কালার, হ্যাঁ চশমা, লাস্ট, হ্যাঁ বল, হোয়াট আর দ্য ফাংশন অফ ইনসুলিন? সামনে চলে যায়, সামনে চলে যায়, বসে পড়তে হবে। পড়াটা পড়ার মতো কিন্তু তোরা সবাই মিলে করছিস না, সেটা কনফার্ম, কারণ এই কোশ্চেনগুলো খুব সহজ। ইনসুলিনটা যদি ফাংশন করতে না বলিস, তাহলে আর ইনসুলিন রেজিস্ট্যান্স কি বলবে, আর তোকে আর ইনসুলিন রিসেপ্টর কিভাবে কাজ করে কিভাবে বলবে। হ্যাঁ এখানে বস, লাস্টে বসে আছিস কেন বল? হ্যাঁ গ্রোথ হর্মোন স্টিমুলেটর, ওকে, দেন হ্যাঁ ইনহিবিট হাউ হরমোন সেন্সিটিভ লাইফেস, ইয়েস হরমোন সেন্সিটিভ লাইফেস। সো ইনসুলিন বেসিক্যালি যদি কিছু বলতে না পারিস, অন্তত এটা যেমন বললো যে গ্লুকোজ কমায়, ঠিক, একদম ঠিক, রাইট। আরটা করে ফ্যাট সিনথেসিস অ্যান্ড ইট বার্নিং অফ ফ্যাট উইল বি ইনহিবিটেড, প্রোটিন সিনথেসিস, সমস্ত এটা হচ্ছে অ্যানাবলিক হরমোনস, রাইট, বুঝতে পার। সো কেউ কেউ পড়ছিস, কেউ কেউ পড়ছিস না, একদম পড়ছিস না। So today's topic is maturation. Before going to the maturations or maturation reflex, Weill reflex, etc., I like to know from you about some functions of kidney. Anyone? Functions of kidney. Kidney কি কাজ করে? Water balance, number 1. Number 2, iron balance, okay. Electrolyte balance. Number 3, waste product, okay. Number 3. Number 4, acid base balance, very good. Number 4. Number 5, blood pressure regulations. Number 5. Number 6, yes, কে বলছিস বল এটা? ইরিথ্রোপোয়েসিস করে, ভেরি গুড। ইরিথ্রোপোয়েসিস করে না, বেসিক্যালি ও ইরিথ্রোপয়েটিন রিলিজ করে, রাইট। রিলেট ইউরসেলফ ফর ইউর সাবজেক্ট। মুখস্থ করা দরকার হয় না ফিজিওলজিতে, সত্যি দরকার হয় না। 10টা পয়েন্টের জায়গায় তুই 5টা বললেও তুই অনার্স নিয়ে বেরিয়ে যেতে পারিস। আমি তো শুনতে চাইবো এইগুলোই, যে অ্যাসিড বেস ব্যালেন্স বলবি, ইকুইলিব্রিয়াম ব্যালেন্স বলবি, কেউ হয়তো একটা কিডনিতে ওই বাজে প্রোডাক্টগুলো বের করে নিয়ে বসে থেকে তোরা বলে দিয়ে ফিনিশ, ও সালা কিছু বলছিস না। So before you have to know the functions of kidney, otherwise you can't process into a patient into the renal system examinations, right? Whenever you are dealing with a patient some sorts of symptoms, now I'm like to questions you, what will be the symptoms may present is related to the kidney diseases? কি কি নিয়ে আসতে পারে? Yes? হ্যাঁ, অ্যাসিডোসিস অ্যালকালোসিস, ওকে মানলাম, নাম্বার 1। নাম্বার 2, আচ্ছা বলতো কিডনি ডিজিজে অ্যাসিডিক ইউরিন হবে না অ্যালকালাইন ইউরিন হবে? হাউ ক্যান ইউ সে যে দিস মে বি ট্রান্সফর্ম অলরেডি কিডনি ড্যামেজ অলরেডি ডান? অ্যাসিডিক ইউরিন হবে, প্রোটনের লোডটাকে বাড়িয়ে দেবে H+, so that will come through the tubular secretions or tubular fluid. Renal tubular fluid comes in the urine as acidic urine. This is one of the criteria for the chronic renal disease or chronic kidney disease. Others, whenever you think that may present as a kidney diseases. Glycosuria, okay, manlam, diabetes followed by kidney damage, is a glucose is coming on, okay, then সিমটমস কি নিয়ে আসতে পারে? পেশেন্টস কি সিমটম নিয়ে আসতে পারে, কি কি সিমটম একদম ডিস্টিংক্ট যে হ্যাঁ এটা রেনাল হতে পারে? দেন ইউ গো ফর দ্য ইনভেস্টিগেশন আর ফার্দার হিস্ট্রি। একটা পেশেন্ট হয়ে ডিলিং উইথ এনি পেশেন্টস, you have to understand the sign and symptom in which system. Otherwise, a patient who is coming with the leg edema and pedal edema, facial swelling, and you are doing the CNS examination for the cranial nerve examination. Is it right? Not at all. Patients coming with a leg pedal edema, that means leg edema, leg swelling, facial swelling is there, abdomen swelling is there, and you are doing the cranial 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Is it right? No. That means you have to understand which system is going to, right? So that's why I'm telling kidney, renal disease, renal problems, what patients may come with the symptoms. কি নিয়ে আসতে পারে? এই একটা বলে দিলাম, pedal swellings and facial swellings. Yes? Hematuria, okay. Hematuria is very important for the renal. Very good. Painless hematuria, one of the important cause or important symptoms of a bladder carcinoma also. Hematuria is one of the most important symptoms you can say in case of urine tract infections. That is also renal. So any patients with sorts of symptom, you can think about the what system is dealing with. Hematuria, number 1. Hematuria you can understand and also in the hemopoietic system also. If platelet count is less, that is also may come as a hematuria, trauma, etc. Hematuria, number 1. Number 2, leg swelling, facial swelling. Number 3, hypertension. The patients having the hypertension, already you told the functions. Patients with some sorts of proteinuria. Protein is a filter. Kidney ki ase? Nephrons are there. Millions of nephrons are there. Okay? Millions of nephrons are for the filtrations. Filtration for what? There is a big molecules like albumin. Albumin emni urine diye asbe na. So it will coming. That means proteinuria. If protein is less, that is a feature of some glomerulonephritis, of some nephrotic syndrome, etc. So these sorts of symptoms is coming as the symptoms of a renal disease. That is very important for you. Which system you are dealing with. What is the hypertension, then uremia, uric acid level, urea level, blood is high. Azotemia, azotemia, uremic frost. What do you mean by uremic frost? Uremic frost is the skinny dusty material will be like that, mainly in the scalp. This is a uremic frost. This patient suffering from chronic kidney disease and azotemia. তার মানে ওর ইউরিয়া লেভেল বেড়ে আছে, ইউরিয়াকে বের করতে পারছে না, এক্সক্রিশন করতে পারছে না, that will come in the skin as a crystal. So in this way, each and every system have some specific symptoms. You have to go through this. Otherwise, second year professional MBBS will be problematic. Hey, you come to the front bench. সামনে চলে আয়। So, renal diseases related complications means you are dealing with some azotemia, polyuria, hematuria, hypertension, fatigue হয়ে আছে, exhausted, কাজ করতে পারছে না, acid balance খারাপ। In this way, the systems are in the chronic kidney diseases. Now, many expansion I can give how it is happening. Suppose patients having hypertension. One of the important cause of the renal disease nowadays is written in somewhere it is diabetes and hypertension. Those are friends. Either hypertension or the diabetes. So both are dangerous for your patients. So how I can explain in 1 to 2, that is how the hypertension causing the chronic kidney disease. So you can understand what is happening in the kidney during the diabetes as well as in the hypertension. Suppose the patients coming with a hypertension only, like 120 by 100. Okay, so this is too much. That is diastolic BP is high, systolic BP is high. It is too much for the long term. Now, what will be effective? Effective area কোথায়? Kidney. The effective area means afferent arteriole. জানিস তো এগুলো? হ্যাঁ, এমন করে তাকিয়ে আছিস তোরা, আমার একটু ভয় লাগছে। হ্যাঁ, আমারই ভয় লাগছে কি আমি কি ভুলভাল বলছি না কি বলছি। So these are afferent arteriole and this is the efferent arteriole. ধরে নিচ্ছি আমি। So whenever you are dealing with hypertension, that means these vessels will be narrowed, right? These will be narrowed. Hypertensive, vasoconstrictions, hypertensive. So this will narrow. Then what will happen? If the blood যাচ্ছে, oxygen আছে. This oxygen will be less perfused into the surrounding tissues. What do you mean by surrounding tissues? Surrounding tissues means my tubular cells. Here are some tubular cells are there, and as well as these are the mesengium. নাম শুনেছিস? These are the mesangial cells, right? Mesangial. How? If this oxygen perfusion of this tissue is less, that means this cell is a mesangial cell. This cell will be stressed. সে অক্সিজেন পাচ্ছে না, সে বলছে আমার তো এটা হওয়ার কথা ছিল না। He or she is telling that he does not deserve the less oxygen. He or she does not know what is happening, hypertension. So he will be fire. সে রেগে গেলে কি করবে? Pro-inflammatory markers release করবে. One of the important is TNF, tumor necrosis TNF 1 beta. তাও ভুলে যাচ্ছে, অনলি TNF বল, তাও ঠিক আছে। সো টিউমার নেক্রোসিস, এই টিউমার এটা কারা? pro-inflammatory cytokines. What will happen? Damage. The messenger cells will say, না বাবা আমি আর পেরে উঠছি না। তখন তারা কি করবে? এইখানে produce excess amount of extracellular matrix. They will produce cell, then they are trying to produce extracellular matrix. So that is of oxygen and pro-inflammatory release. So that is done by the formation of the extracellular matrix. So this matrix, what is happening? Fibrosis. histamine to the stiffy. So this as a conformation is a fibrosis. And then if this is fibrosed, then there is a problem of GFR. Glomerular filtration rate. What is the normal value? 120. Now, if this GFR will be reduced due to these extracellular matrix formations, কেন ফিল্টার করতে পারবে না, এখান থেকে আর কিছু ফিল্টার করতে পারছে না। এটা টিউব, these are the tubes, and this এখান থেকে কি করে, আমাদের ব্লাড থেকে নিয়ে পারছে না, glomerular filtration rate less than 90 হয়ে গেছে। If glomerular filtration rate is less than 90, কি ইউনিট GFR ml per minute per 1.73 meter square per minute per 1.73 meter square. This is the actual one. If it is continuous for more than 3 months, then only we can say this is a chronic kidney disease. Then we can say that these patients transform into the chronic kidney disease, and that ultimately into the end-stage renal disease, and then renal transplantation will be needed or dialysis. In this way, all fashions, all the diabetes also, diabetes কি থাকে, sugar থাকে, sugar will be precipitated here, sugar precipitated here, and glycation of the others. Glycation means সুগারের সঙ্গে প্রোটিনের যোগাযোগ হয়ে গেল, সুগারের সঙ্গে লিপিডের যোগাযোগ হয়ে গেল। All are glycation is happening, and then also the narrowing of the arterioles. In this case, sugar but remember, up to this class, that hypertension, diabetes, polycystic ovarian disease, these are the most important causes of the chronic kidney disease, and it is defined when the GFR is less than 90 and more than 3 months. If it is less than 3 months, then it is called acute kidney disease or acute kidney injury. Nowadays, a new term is coming, that is acute kidney injury. That is also injury, and that is also chronic kidney injury. Chronic means more than 3 months, less than 90 GFR. Finish. বোঝা যাচ্ছে না, মাথার মধ্যে সব ঘুরছে বাই বাই করে? So in this way, if you read, you can give any explanation from this. You can write any explanation, nobody can damage you. So in this way, this will form, sometimes this will form as a glomerulonephritis. This is fibrosis, it is called sclerosis, and that is the term kind in your book, that is the glomerulosclerosis. Sclerosis means কি, fibrosis কি হবে হলো, extracellular matrix সে এলো কি করে, pro-inflammatory marker কেন রিলিজ করলো, the stressful আমাদের messenger cells. Then why messenger cells feeling stressful? Because it is a lack of oxygen. Why it is less oxygen? Because the vasoconstriction is there due to hypertension. So in this way, you have to think and go for the further investigations and other than this. So in this way, all the chronic diseases are important. Acute disease is also important. One of the important function you missed, that the kidney has important function, that is a removal of some unwanted drugs or toxins. Like আমরা রেগুলার কোনো না কোনো খাবারের মাধ্যমে কিছু না কিছু টক্সিনস খেয়ে যাচ্ছি, যেটা কার্বোহাইড্রেট toxins. Kidney is helping to the out for the toxins. There are important functions we miss, that is the removal of the toxin or drugs. That's why if any drug is metabolism to the kidney and the patient is suffering from chronic renal disease or chronic kidney disease, we have to avoid. Right? Like one important drug is suppose amikacin. It's very rare, commonly used. Any patient is coming with renal failure or kidney disease, chronic kidney disease, we never prescribe the amikacin and gentamicin, because these are the toxic. You will learn in the second year pharmacology, but still, if it's 5, these have to understand what is happening in the mesangial cells. Mesangial cells are very sensitive, and these are the never ever want to decrease the oxygen and any stress to these cells, right? So in this way, you can detect what is the chronic disease. The chronic disease by GFR fund are ekdom clear. Relatives also may come with the presentations of your hypertension. That means at least you have to go for a urine RME, urea creatinine, etc. Because you have to understand whether the kidney is going into detect or is problematic or not due to the hypertension. Because it maintains the hypertension, water balance is there, there is electrolyte balance electrolyte balance also there. So in this way, this is happening to in your day-to-day life and day-to-day classes. Kichuta boja gelo. So renal system is very important. Each and every part you have to enter into the. You have to enter means your mind enter into the glomerulus. Everything is happening there. You have to understand in a big way that this is the glomerulus. This is the nephrons. This is the mesangial cells. Blood vessels are coming with the blood, huge pressure. This pressure due to this narrowing of this, and so the narrowing is if any vessels like cell গুলো আছে, this cell will get less oxygen. এখানটা পুরো হয়ে যাবে মনে করো. So this number, the amount of blood will be less, the oxygen will be less, so perfusion will be less. If perfusion will be less, then the messenger cell will get less oxygen. Then he is stressful. Messenger will be angry, and he will produce the TNF-1 beta. There is a pro-input. You can see some cytokines. Any stressful cell, any stressful, আমি আগেও বলেছি, if fat cells are angry and stress, যে আমাকে বেশি পরিমাণ ফ্যাট তৈরি করতে হচ্ছে, এত তুমি গ্লুকোজ খাচ্ছ, ইনসুলিন কমাতে পারছে না সেই গ্লুকোজে, হাইপার ইনসুলিন হয়ে ইনসুলিন রেজিস্ট্যান্স হয়ে গেছে, then fat cell will be stressful. The fat cell will release free fatty acid as well as cytokines to produce the inflammations. So one of the important in your class was there, in obesities, in insulin resistance, there must be inflammations. Inflammation chronically gele, then you transform into the metabolic syndrome, right? So all are related. Relate yourself, try to relate yourself. At the final year, you can understand what is I am telling you to do. So this is will be helpful for your day-to-day practice also. You won't have to think what is the patient coming with the symptoms. It is the symptoms of digestive system. It is the symptoms of renal system, whether CNS, whether the cardiovascular system, whether which is the presentation of the respiratory system. You have to detect in 1 to 3 seconds only. If you see the patients having hypertension and patient respiratory distress also, then you have to carry for a fast walk. So that is what job. That is what going to be done. You are not a nurse. You are not to be attendant. Not going to be a doctor. The patients will believe you. If you have knowledge, you can rescue her. You can't save every patient. But if you mistake that, then whenever your patient is dealing in spreadal edema, swelling of the face, and you are not thinking at all about the renal system, that is a crime. বুঝতে পারছিস? So, because in the flow of such endocrine system, I am entering into a different topic. This is a mixture. There is no relations is there. So I want some understanding with you and me that what you learning about the renal system, because renal system is very important for your exam as well as in our clinical setup also. Now bladder. What do you mean by urinary bladder? It is the anatomy. হয়েছে anatomy? পড়েছিস anatomy? হয়েছে। হ্যাঁ বলেছে মানে কেউ পড়েছে। Okay. Now tell me some sorts of chemical, some sorts of structures of the bladder. শুনিয়ে করো। Trigon, very good. Yeah? কি বলছে? কি নাম? ও আচ্ছা ঠিক আছে আমার মনে নেই। আর ইন্টারনাল কি স্ফিংটার? অ্যানাল স্ফিংটার? তাহলে So you have to tell na, internal urethral sphincter, external urethral sphincter. Then any muscles of the bladder? Huh? They are two muscles, right? Nerve supply. And এইভাবে জিজ্ঞেস করে মাসেলস, নার্ভ সাপ্লাই, ব্লাড সাপ্লাই, ভেন্স, তাই তো এইভাবে জিজ্ঞেস করে না? ইয়েস, নার্ভি? নো, সেটা একটা কমপ্লেক্সকে বলছে হয়তো, মেবি। ইট ইজ এ প্যারাসিম্প্যাথেটিক অর সিম্প্যাথেটিক? বোথ, বোথ বলেছে, মানলাম, আমি আসছি। দেন টেল মি থ্রি নার্ভস, নেম অফ দ্য থ্রি নার্ভস। Pudendal nerve, not pudendal. Pudendal nerve. It is supplied to? Yes, external urethral sphincter. Very good. Then? Huh? Vegas এখানে লিখব, ইউরিন করে ফেলবি। So, three nerves is very important, that is hypogastric. তাই তো? তারপর হচ্ছে তোর পুডেন্ডাল, আর একটা হচ্ছে তোর পেলভিক। পেলভিক স্প্যাইন এখানে কেন আছে? পেলভিক নার্ভটাই দুটো ভাবে পার্ট থাকে, একটা সেন্সারি, একটা মোটর। সেন্সারি অ্যান্ড প্যারাসিম্প্যাথেটিক। ওই প্যারাসিম্প্যাথেটিক বলছিস? That is through the pelvic nerve, and also pelvic nerve produces the sensory nerve also. Before going to micturition, you have to understand this. That is why that is important. But now my question is in backside. What is the importance to know the micturition reflex or anything else micturition now? Ki jana darkar ache, ki ama hamori ache jana. So some sorts of clinical symptoms are there. That's why you have to understand what is happening now. I am giving an example of my patients. Patient presented with বোধহয় 8 years male patient presented with frequency of urine. Increased frequency of urine means 75 times per day. It's happening. Just patient come with this symptom. Nothing else. No problem is there. So I thought, I asked the patients, when it is happening? It is night? No. It is all the time. He can bed waiting, pant waiting, without any incontinence is happening. Continence means holding of urine. We are in the class, some other students will feel, I can go, but you can restrict yourself. You can restrict yourself until unless a proper place, proper mind, you can see, you can fight because of your voluntary control is there from the cortex. So micturition is in cortex, in the midbrain, in the pons, in the spinal cord, each and every segment is important for the micturations. So I treat the patients for 1 month some drugs, that is a anti-cholinergic drug, anti-muscarinic drugs rather. Now the term is, I have uttered that the muscarinic drug, that the muscarinic receptors are there. The muscarinic is a contraction for the bladder. I thought primarily that the bladder is overactive due to this happening. Overactive means 1 to 2 drops of urine is coming into the bladder. You know that is the kidney. So bear with me. So suppose this is ureter, and this is the bladder. Okay, and this is the muscle, you already told, and this is the trigon. So this is bladder. So ureter, kidney is happening, and this is the urethra is going on. Male and female is the difference. I'm coming if time permits. So I suppose that this bladder is continuously contracting, so I must reduce, I must treat the anti-muscarinic effect, and some drugs it is there. I prescribe a little bit better, but still come after the 2 months. No sir, no response. So my mind was that there is whether it is a cortical problem or the spinal cord problem. These are the problem happening here. This is a nerve problem, neurological. I go for investigations. And lastly, I thought, chalo ekta MRI korei ni. Why? Because in the sacral segment, 3 and 4, these are mainly control, and also the thoracolumbar system. So after the MRI of the lumbar spine, I know this is a report given that a huge tumor is there. Huge tumor is there, to suppressing the parasympathetic tone as well as sensory system is not coming. And that is removed in the Chennai Apollo, and he is fine now. So these are the symptoms you may came across like that. This is very rare. But what is the common? Common is the incontinence. Sir, আমি কাশি হলেই আমার ইউরিন বেরিয়ে যায়, কাশি হলেই আমার ইউরিন বেরিয়ে যায়, বা pregnancy period, mother is telling the urine is going on, he can't hold this, that is called stress incontinence. Such like that, there is a overactive incontinence, overflow incontinence. 75 years male patient, prostate is high, prostate টা থাই কোথায়, এখানটাতে বড় করে একটা ব্লাডার আছে, বুঝলি, কত বড় একটা ব্লাডার রাখা যায়, এর ছোট করে দিই, এইখানেতে আমি এটা ইউরেথ্রা করলাম। সো এইখানেতে আমার একটা স্পিন্টার আছে, কি নামটা, ইন্টারনাল, এখানে ইউরেথ্রা, কথা বলবি না, muscles are there, receptors are there, okay. So this is internal urethral sphincter, external urethral sphincter, right? In the male, there is a prostate here. If 75 at age, then hypertrophy of the prostate will be there, so that will compress. So if it is compressed, then full urine will not pass through this. Continuously সে বারবার যাবে, অনেকে যাদের রিলেটিভরা দাদু বা 65 এজ, তারা অনেকে বলে বারবার যাচ্ছে, that is due to the prostatic hypertrophy or benign prostate hypertrophy, BPH বলা হয়, benign prostate hypertrophy. So in this case, we call this is the overflow incontinence. In this way, stress incontinence during the pregnancy or coughing, snitching, so you have to think what is happening to holding. That means we can hold urine and we can void urine. So whenever your bladder is going to feel, we can hold that. এমন তো নয়, আমি তো সেই বাড়িতে 7টার সময় ইউরিনেশন করে তারপরে এখন পাঁচে যাবো। So why? Which is contrary, which is in my inner sense that this is a class, I can void here. Cortex. So any patient with stroke or neurological disorder, depression, anxiety, cortical dysfunctions, he or she will void anywhere, no problem. So in this micturations part is very important for your nerves, receptors, pathways, spinal corded layers, sacral segment, thoracolumbar segment, pons, midbrain and the cortex. Finish? এটা বোঝা গেছে? Now, suppose this is the brain, cortex. Now this is a pons, and now this is the spinal cord. This is the thoracolumbar, and this is sacral 2, 3 and 4. কথা বলবি না, গুনগুন করে। T12 micturition, and S2, S3, S4 is responsible for our micturition. Suppose this has to hold. Hold means what? Have to contract. দুটোকে কন্ট্যাক্ট করতে হবে, নইলে আমার হোল্ড থাকতে পারবে না। আর কি করতে হবে? এই ডেট্রুসার মাসেল যাতে কন্ট্যাক্ট করতে না পারে, দ্যাট মিন্স রিল্যাক্সেশন। সো S for S means storage for sympathetic, very good. S for S. You can be asked in any exam in oral. This is a reflex. Sympathetic storage. Pons এর দুটো সেন্টার থাকে. One is called pontine storage center. Another is called pontine micturating center. বুঝতে পারছিস? There are at least 4 receptors in the bladder and urethra. Number 1, it is a M3 receptor. Number 2, beta 3 receptor. Here, in the internal urethral sphincter, and the external, there is N1 or nicotinic receptor. What are the neurotransmitters responsible for the receptor? Muscarinic. K neurotransmitter. Muscarinic. Well, अरे भूल बोलना क्या है? Acetylcholine. Very good. This is for acetylcholine. Beta 3. K. Again, nicotinic, acetylcholine. So, during the holding or storage of the bladder, আমরা এখন হোল্ড করে আছি। এই দাদা এখন কখন থেকে বাথরুম পেয়েছে, দাদা কিন্তু হোল্ড করে আছে, শুতে পায়নি, অফ ছিল। So he can hold storage center as well as systemic, sympathetic. What is happening? এমন তো নয় যে পুরো ফাঁকা হয়ে আছে, মনে করো আমাদের অল্প ইউরিনেশনস জমা হয়েছে, ইউরিন জমা হয়েছে through this way, right? So this will sense as a stretch receptor present in the detrusor muscle. So now fifth receptor is present in the detrusor muscles. Suppose these are the fibers is coming as a stretch receptor fiber. The stretch receptor fibers goes to the sensory fibers, and that will go into the sacral region first. Sacral, thoracolumn, 2, 3 and 4, and this is T11 to 12 and L2. যেই গেল কি গেল, এ সেন্স করলো যে কিছুটা জমেছে, but this sense was very low frequency, low sensitive. This low, when it is low, then this information bypass this one and then go up into the cortex, telling that some sorts of urine has been deposited, some, and that's why the senses, and then from there these will come into the thoracic level, into the thoracolumbar level. For what? For the activation of the sympathetic system. What are those? Sympathetic system means hypogastric nerve. So hypogastric nerve will like that. It will go into the beta receptor. Before that, there is a ganglion, inferior mesenteric ganglion. ভুলেও যদি যাস কোনো দরকার নেই, একটা ganglion থাকে, then it goes to release norepinephrine. Right? Now, beta 3 receptor, whenever it is stimulated, then your detrusor muscle will be in relaxed form. So, in beta, there is minus. হয়ে যাচ্ছে? And then also it goes to internal urethral sphincter. What does it mean? কি করতে হবে একে যদি হোল্ড করতে হয়? Contraction. So চলো কন্ট্রাক্ট করে বসে আছে। So what is happening? Detrusor is relaxing and internal urethral is key contracting. Now another part is coming down sacral region, then come to here to activate this one also by releasing the acetylcholine nicotinic receptor, and then it is also contracted. K কে করছে এটা বাবা? কর্টেক্স। কর্টেক্সের সঙ্গে এটা কে? এই যে এটা এলো, এটা কে? দিস ইজ পুডেন্টাল নার্ভ। নাও ইউ আর রিলেটিং, ইট ইজ এ পুডেন্টাল নার্ভ। Pudental nerve, preganglionic fiber will come to the fire as a non-acetylcholine for the contraction of the external urethral sphincter. So external urethral sphincter contracted, internal urethral sphincter contracted, detrusor muscle is not contracted, relaxing. তাহলে কি voiding হবে? হবে না। So this is the storage. This is the storage, and we can hold. We can hold it now also, all of us, because cortex. Cortex কে আমি সিগন্যাল দিচ্ছি আমার জমেছে, কিন্তু voluntarily controlled. This one, it is more powerful. This is voluntary control. আমি এটাকে কন্ট্রোল করতে পারি, এবং একটা এক্সারসাইজ বলা হয়, তাকে বলা হয় যাদের মনে করার এরকম আছে, টু হোল্ড ইট, টু ট্রাই টু কন্ট্রাক্ট, অ্যানাসমিটারের মতো। সো কেজাস এক্সারসাইজ ইজ ফর দিস strengthening of this external urethral meter, that is only the voluntary control, and internal urethral sphincter is involuntary control. কন্ট্রাকশন হতেও পারে, রিলেকশন হতে পারে, ও কোনো ঠিক নেই, নিয়ে আমাদের করে হবে। এটা আমাদের এক্টের বাইরে। আমি একটা কাজই করতে পারি, দ্যাট ইজ এক্সটার্নাল স্ফিংটার, ইউরেথ্রাল স্ফিংটারকে আমি কন্ট্যাক্ট করে রেখে দিতে পারি টু হোল্ড দ্য ইউরিন। এটা রিল্যাক্স হয়ে গেলেও এইখানে আমি ওকে আটকে দেবো। That is why if any patients in male patients is prostate is there, then that will be a problematic, because this is a little bit non-functional external urethral meter. So you can do the incontinence. So continence means holding, incontinence means beriyage. Is overflow, stress, overactive, etc. Neurogenic bladder also there. It's a different topic. I have not gone to details. এইটুকু বুঝতে পেরেছি যে how can you hold our storage? That means we are using specially the sympathetic chains. We are using mainly the sympathetic chains, and this way this is happening. এটা এখান থেকে এসছে কেন? এটাকে ছড়িয়ে দিই, এটাকে এখান থেকে, remember these sympathetic chains or sympathetic fibers always come from the thoracolumbar segment. আবার বলছি, thoracolumbar segment and sacral segment. Spinal cord এর এই দুটো segment is important for our micturations. Thoracolumbar is responsible for sympathetic, and sacral is for the parasympathetic, PS. Sympathetic means thoracolumbar, ST, and this is for sacral is a parasympathetic. আমি এখনো প্যারাসিম্পাথেটিক কথা বলিনি। So what does it mean by parasympathetic? Now I am coming. Suppose এখানে পুরো ইউরিন জুড়ে গেছে, পুরো ইউরিন ফুল। Now tell me, when you feel urge of micturition, what is the ml? জানা আছে? 150 to 200 ml inside the bladder, we can urge or feel the urinations. Up to 400 to 450, we can hold. Painful after the 500, that is painful. And then if it is more than 500, then automatically it will come down, can't hold, is voluntary also. That is huge amount. So suppose this is the amount is at 300 ml. So now the stretch receptor is more stretching, because detrusor muscle is stretchable. Detrusor muscle is stretchable. This stretching of the happening. Now inside the bladder there is a law that is called Laplace law. Laplace law পড়ানো হয়েছে, which is physics. So if it is the volume and it is the pressure, then first of all blood pressure is high, it's normal. Whenever urine is collecting, some sorts of pressure will increase. This pressure is increasing, right? Then it remains constant. Why? Because the bladder is relaxing, stretching, space দিচ্ছে ওকে. That's why pressure is constant, but volume is increased. But whenever it is 400 ml, it will spike. So in his book, this is written as a 1A, 1B, and 2, and just go through our book. That is the Laplace law. It is applications P for whether 2T by R children. Is a radius is increasing, so the pressure is decreasing. Tension is increasing also, but radius is much more increasing. So pressure is decreasing or remains constant in this phase because it is the Laplace law, right? So go through your book. It is written in your book, in any book. Probably it is there. Now I am come to the concentration into this stretching of the bladder. Whenever this is huge stretching, the sensory receptors will come into the sacral region, and then it will go up to the cortex. Then it will stimulate the basic stretch page. Then pontine nicotine center will be stimulated. So pontine nicotine center will be stimulated, and that's why this and cortex then comes into the center. Then from there fibers are coming into the thoracolumbar to inhibit the sympathetics. Sympathetic কে যদি ইনহিবিট না করি তাহলে তো আমার হবে না, কারণ এ তো ব্লাডারকে রিল্যাক্স করে, বিটা 3 রিসেপ্টর, তাই তো। আর কি করছিল? কন্ট্রাকশন করছিল ইন্টারনাল ইউরেথ্রাল স্ফিংক্টারকে by releasing the norepinephrine from the thoracolumbar level. So now this is inhibiting here, this fiber inhibiting here, but it is stimulating the sacral fibers. Sacral fibers means pelvic fibers, pelvic nerve fibers. Pelvic nerve fibers now stimulate and it goes to the M3 receptor to release the acetylcholine for the contraction of the detrusor muscle. বুঝতে পারছিস? তাহলে MEM3 হচ্ছে mainly for the contraction, beta 3 for the relaxation, alpha 1 in the sphincter internal, and N1 is the external. Finish. চারটে মেন রিসেপ্টর আমার আছে, তাহলে চারটে রিসেপ্টরে কাজ করব কি করে? If it is have to contraction, then you have to inhibit the beta, then you have to inhibit this one and also stimulate this one, M3 muscarinic receptor through the acetylcholine, and that's causing the contraction of the detrusor muscle. Detrusor muscle যদি contraction না হয়, এটা যদি আমার contract না করে, the pressure will come now, not down. And if it is not relaxed, if it is not relaxation, then it will not open. Urine is coming. Now কি করবে এটা? ওই যে পন্টাইন নিউট্রিয়েন্ট সেন্টার, ওখান থেকে যে ফাইবার এখানে এসেছিল, and that will decrease the activity of this nicotinic receptor or this acetylcholine to causing the relaxation of the external urethral sphincter. তাহলে কি হলো এখানে? আমি সিম্প্যাথেটিক কে ইনহিবিশন করলাম, আর প্যারাসিম্প্যাথেটিক কে যে স্যাক্রাল সেগমেন্টে হয় তাকে স্টিমুলেট করে দিলাম। স্যাক্রাল সেগমেন্টে যখন স্টিমুলেট করলাম, then its fiber goes to the M3 receptor and then it causing the contraction of the detrusor muscle. হয়ে গেল আমার কাজ, ব্লাডারকে কন্ট্রাকশন করা হয়ে গেল। নাও আমার নেক্সট কাজ হচ্ছে ইন্টারনাল ইউরেথ্রাল স্ফিংক্টারকে রিল্যাক্স করব, as well as I will relax our external sphincter also. External sphincter is voluntary control. Now whenever you go to the bathroom after my class, now your perception in the cortex will be there, that now it is we can find time to go. কে বলবে এটা? কর্টেক্স বলবে। তখন কর্টেক্স কি করবে? It stimulates the pontine nicotinic center and that will go to inhibit the pudendal nerve. That is a voluntary control. In our control, আমি জায়গা পেয়ে গেছি, কেউ আমাকে করছে না, দেখবো হোয়াইট যে কেউ আমাকে দেখতেছে, কেন করছিস, কেন দেখছিস, what is happening? It's stimulating that inhibitions. So all are our cortex. We can hold urine, we can only victuate or void the urine only when proper place, proper time, you are seeing, you are casual, you are relaxed, then only your pontine nicotinic center will be stimulated, and these stimulations will go into the inhibition of this pudendal nerve for the relaxation. ইউরিন হয়তো এখানে চলে এসছে, এত প্রেসার, আমি এতক্ষণ ধরে বলছি 1 ঘন্টা ধরে, শুরু থেকে হয়তো তার 300 ছিল, 400 হয়ে গেছে এখন, সেটা আমার চাইছে, but he or she can't avoid this. Here is the class. You can't do this. So what is happening? You were voluntarily, this is in the contractile space, contraction to release acetylcholine nicotinic receptor. So in this way, whenever you are much more stretching, the state receptor sensory fibers will go into the sacra and go up to the cortex, inhibit to stimulate this one and to inhibit this one. Storage center ke inhibit করে, quantile nitrogen center ke activate করবে। যে activate করবে, it will come to the thoracolumbar level segment to inhibit the sympathetic system. That's why beta 3 দিয়ে যাতে blood pressure relax করতে না পারে। Similarly, it will come to the sacral segment and then it goes to the fiber into the M3 level for the contraction of the blood pressure. Finish? As well as it is due to the inhibition of this. So this is inhibited, internal urethral sphincter will be inhibited, and that is why it is called relaxation. তাহলে এটার contraction, এটা relaxation হয়ে গেছে। Now you go into the bathroom, nobody is seeing you, pressure is there, and now your feel is weak and quiet. So your cortex will tell here the pudendal nerve to suppress your contraction, to release, to decrease the release of acetylcholine and nicotinic receptor so that it can relax. Now the urine will pass. Now one important thing is that male urethra is much more longer than the female urethra, and there is no prostate gland as well as internal urethral sphincter মেয়েদের থাকে না। Prostate gland and this sphincter is absent for female, as well as the urethral length is very short because এইটা নেই, prostate নেই, how is so long? It is 3 to 4 centimeter only, and that's why if your fighting training is a toilet training is a wrong places, infections may carry due to the river, so that readily can present to your OPD as a urine tract infections. Till now, if any female patient or female child coming, he goes to the school and bathroom and toileting, coming with the vomiting, fever, we always suspect as UTI. Because respiratory urinary tract infections may be there. Because thinking in my mind that there is a short urethra is there, the infections carry to the bladder as well as in the kidney. In the bladder, it is called cystitis. This is in the bladder infection. If it is go to the urethritis, if it is go to the kidney, it is called pyelonephritis. So itis means inflammation is going on because of infections. So in case of female, I recommend proper place urination is a must. Proper hygienic way, is a must to avoid the recurrent UTI, because recurrent UTI may cause renal scarring, kidney ke scar kore debe, fibrosis korbe, messenger cell sab kichu bhab, these will happen, and ultimately recurrent causing the kidney damage also. So UTI must be avoided by doing the good practice of toileting. In case of female specifically, hopefully now it is now clear how can we hold the urine and how and when we can void the urine. After the micturition reflex, there is another reflex, is called voiding reflex. What does mean? যখন তুমি ইউরিন করছো সেটাকেই বলা হয় voiding reflex. কি সেখানে হবে? What is happening there? They are happening that mic নেই, mic আছে নেই, তাও বলার জন্য ভালো। So what is happening there? This is the reflex is going on, voiding reflex. What does it mean? That mean from the sacral segment, S2, S3 and S4 goes to the M3 receptor for the contraction, as well as this pudendal nerve inhibitions is going on to the further relaxation. Or you can say better that due to the stretching of the bladder, due to the stretching of the bladder, is going on by the parasympathetic system to activate. Sensory fiber activates করে দেবে parasympathetic system কে to cause the voiding properly. এখানে কোনো disturbance নেই, properly voiding করো, that is called voiding reflex. Probably it is not written in your book, but your good book is maybe written micturating reflex, then the voiding reflex. Okay, now it is clear. Any questions from this? Okay, in gist, due to storage we can hold by the activating the sympathetic system, right? Sympathetic system means hypogastric nerve. It is present in the thoracolumbar segment, that is mainly T11, 12 and L2. Thoracolumbar system is there, and this is the activation of the pontine storage system that is present in the pons. So micturating system center, you can say, present in the pons. Now this cortex will inhibitions of the contraction of the external, as well as it activates the sympathetic system. Sympathetic system go in the two types, two ways. One is the beta 3 and the alpha 1. Alpha 1 causing the contraction, and beta 3 is causing the relaxation of the adductor muscle. That is why we have storage. And now with the voiding, there is a pool of urine is present inside the bladder. So in this case, you can use the parasympathetic. What does mean by stretching, going to the cortex, inhibition of pontine storage center, activation of the pontine micturating center, then is come to suppress the sympathetic. Bhavati tham. তুমি অনেক করেছো, বিটা 3 কে তুমি স্টিমুলেট করে রিল্যাক্সেশন করেছো, এবার আমাকে ডেট্রুসার মাসেলের কন্ট্রাকশন লাগবে। কে করবে? M3। কাকে দরকার? পেলভিক নার্ভ, প্যারাসিম্প্যাথেটিক, এসে তাকে কন্ট্রাকশন করবে। আমার আরো দরকার ইন্টারনাল স্ফিংটারের রিল্যাক্সেশনস। সে কি করবে? সাপ্রেশন অফ দ্য সিম্প্যাথেটিক, অলরেডি ওটা সাপ্রেসড হয়ে গেছে, দ্যাট ইজ রিল্যাক্সেশন। নাও মাই সেন্টার will work at the bathroom or the proper place. Whenever you can feel the freely properly, you can void. Then only this voluntary we can relax this. Voluntary we can relax the pupillary nerve so that the urine can pass and you can void, followed by the voiding reflex. Finish.
Firstly, we discuss the quality. First, we discuss the practical manuals. Up to the what is your syllabus, you know that we discuss the laboratory hazards up to today class. What we are completed, we completed hazards. You know hazards, laboratory hazards. You know there are 4 types of hazards. What is the definition of hazards? You know hazards. You know, you don't know. तुम तो रहने दो. If I will ask you, you know the table of 2, you will say no, sir, because I know you. From the day first when I was met you, you always say no for everything. You complete your manual, no, sir. You know this thing, no, sir. If I ask the question, no, sir. All of you. Only 3 and 4 students give the answer in the Viva. Why? If we will teach all of you, then we accept that you give the answer. Understand? You know your exam date comes near, or exams comes near. The time is become very short, and we ask the question from the whole syllabus in the Viva. In the previous classes, HOD sir asked the questions and 2 or 3 students give the answer. I don't know what attitude you will kept in your mind. I don't know, because you are not a child that we are giving you spoon feeding. Understand? We are not providing you a spoon feeding of the syllabus. You know the syllabus, what is in the criteria, and what we are going to teach you, what we are completed, how much syllabus is completed, all of you know that. And this is your responsibility that you improve yourself. This is this is not a responsibility of the teachers. Understand? This is your responsibility. If maximum 5 or 10 students give the answer from 50 students, then I think the result of this batch is only 15% from 50 students. From how much to 150? It is only 30 to 40%. So there are different things you will try to work hard, understand the concept and complete your syllabus first. So I will talk about the practical syllabus that today we are up to how much syllabus we completed. That we complete laboratory hazards, then we completed qualitative test of the practical syllabus, that is abnormal urine analysis. That is important. In normal urine analysis, we perform some of the tests like test for creatinine, test for urea. We left out most of the test, I know. But in abnormal urine analysis, we complete test for abnormal urine constituents. Okay? In abnormal urine constituent, we already classified that the physical properties of the urine, abnormal physical properties of the urine, which is compared with the normal one. Same as chemical test, which is different from the normal one. We perform test from different constituents and all the syllabus. We also perform this test up to this mark and also complete in the demonstration also. Now in the next quantitative test, we completed majorly 4 tests. Majorly 4 tests. Which one? Also tell the method's name also. You will tell the name of the test which we complete today. How much test we perform today? From the syllabus, you tell all the name with the methods. This is now that time NMC reduced the syllabus of your practical syllabus and it is very small. From the previous year, there are so many tests. General reaction of the protein in the precipitation, half saturation, full saturation, saturation by heavy salt, saturation by organic solvent, saturation by heavy acids. There are different tests, Osazone test, in which we identify the slides from the microscope. Too much syllabus. And now a time, this is reduced syllabus, nothing in the syllabus. And you don't know the test with the procedure name. Students, I repeat again, it is important that you focus on your study. Be serious. There are 4 tests. First one is blood glucose by GOD-POD method, serum creatinine by Jeffries method, blood urea by Dams method, and serum protein by Biuret methods. So all this practical, all the biomolecules, quantitative estimation of these biomolecule in the blood, we perform it and also we know the theoretical portion. Now in your syllabus there are some other constituents also, like estimation of total cholesterol, estimation of SGOT, SGPT. SGOT, you know, it's the enzymes, liver enzymes. SGPT is the liver enzymes. Okay. So this is given in your syllabus that you have to know the procedure, how it is calculated and what is the normal range of this biomolecules. Okay. But it is not mandatory to perform in the lab. It is not mandatory to perform in the lab. So today I demonstrate you the estimation of cholesterol by enzymatic method. I will tell you the principle, I will tell you the procedure, I will also give you the formula to calculate it, but it is not mandatory that we going to perform this test in the lab. Okay. If you want to correlate, if you want to taking the value, you will go to the lab, see the reports. If you want. ठीक है, इतना आपको करना है, इतना आप देख लीजिए, ठीक है। तो राइट डाउन हेडिंग फर्स्ट, एस्टिमेशन ऑफ सीरम कोलेस्ट्रॉल, estimation of serum cholesterol. I think your syllabus is complete, your lipid metabolism is complete, then you already know the serum cholesterol. What is the meaning of cholesterol? You already know, I think. Last one. Yes. Yes. Formation of steroids. Okay. So it is important. Cholesterol is important for the body because through the cholesterol we can helpful for the formation of vitamin D, helpful in the formation of bile acids, bile salts, and also helpful in the formation of steroid hormone. Okay, because steroid basically the structure provided in the steroid hormone from sterol. Okay. Sterol. If you see the chemistry of the cholesterol, there is how much carbon molecule is present? 27 carbon molecule is present. Okay. But about the fate, but when the level of the cholesterol, this is the normal level of the cholesterol. Okay. What is the normal level of lipid profile? Lipid profile, you know? What is lipid profile? Lipid profile is the quantitative estimation of all lipid molecules present in the body, all the fat molecule present in the body. Okay, it is total cholesterol, normal level is 150 to 200 mg per dl. Okay, triglyceride, it is up to 150 mg per dl. Okay. HDL, it is 30 to 60 mg per dl. LDL, which is a bad cholesterol. I will not give you the definition because I already taught you why it is good cholesterol, why it is bad cholesterol. It is up to 120 mg per dl. Okay. Now VLDL, very low density lipoprotein. Let's have different calculative formula. It is Tg upon 5. mg per dl. Okay. So this is major 5 profile which we calculated through the lipid profile. Okay. And if the cholesterol level is increases from the normal one, the condition is referred as hypercholesterolemia. Hypercholesterolemia. Why stand for anemia? Anemia stand for blood. Okay. Now, what is the reason for hypercholesterolemia? Tell me the reason. वो कर दिया सर क्या? Tell me the reason of hypercholesterolemia. बॉडी में कोलेस्ट्रॉल क्यों बढ़ जाता है? एक मिनट, कोई नहीं बोलेगा. Which kind of fat? What are the sources of the cholesterol? Answer of a single question. Tell me only one disease in which cholesterol level is high. Very good. Atherosclerosis, I will tell, but it is a symptom of hypercholesterolemia. Atherosclerosis. The also disease, I will write the disease atherosclerosis. First one. Second one is diabetes mellitus. Very important. Okay. In the case of MI also, the level of the cholesterol is high. myocardial infarction. Any other? In the case of CHD, CHD stands for coronary heart disease. Okay. So from this, all of this condition, this is happen generally seen this condition hypercholesterolemia in all this disease, and also sees this hypercholesterol in obesity and pre-diabetes. Okay, so that is important to know the condition of the cholesterol. That's why we are going to perform this test. Okay, so the value of the cholesterol we also calculated. I am not tell you about all these fractions. In the next class, in the upcoming class, we discuss all of this. So first you make the heading estimation of serum cholesterol, then write it in this after this introductory part. Total cholesterol in the blood. Total cholesterol in the blood plasma of normal person. Total cholesterol of blood plasma of a normal person may be presented in amount between 150 to 200 mg per dl. Between 150 to 200 mg per dl. The amount may be raised in severe diabetes. The amount may be raised in severe diabetes, biliary obstruction, biliary obstruction, and also in nephrotic syndrome. So there are the methods called CORD-PEP method. It is, we directly give the name of the method. It is enzymatic method. The name of the method is CORD-POD. You think so? What is the full form of CORD-POD? It is cholesterol oxidase peroxidase. CORD-POD method for. Okay. So what we required for this test for the CORD-POD, you will write the some points regarding this method. It is endpoint calorimetric method. Endpoint calorimetric method. There are two types of method. First one is kinetic method. Second one is endpoint reaction, kinetic reactions. Okay. So this is endpoint calorimetric methods in which calorimetric. Okay. So should I spell of this calorimetry? Okay. And reagents required. बस इतना लिख देना. Calorie single endpoint calorimetric methods and kit based method. बस उसको काट के लास्ट में ब्रैकेट में लिख देना kit based method. Just write it kit based method. Okay. Now write down the principle. Principle में लिखिए. The estimation of cholesterol involve following reaction. The estimation of cholesterol involve following reaction. Okay. So write down the reaction. It is 4 amino antipyrine. 4 amino antipyrine. So now you will see the reaction. This all reaction is same like GOD-POD. Quinonamine. Because the principle of GOD-POD also same. When the glucose is act on, when the glucooxidase is act on glucose, it is converted into gluconic acid and hydrogen peroxide. When this hydrogen peroxide react with oxidation of phenol and 4 amino antipyrine, it form red quinonamine complex. This is the principle of what? GOD-POD. So this principle is also same. When the ultimately cholesterol esterase, what? They remove the esters from the cholesterols into fatty acid. What is the function of the esterase? Breakdown. So ultimately break down cholesterol into fatty acid. Then after breakdown, it act this cholesterol oxidase act on cholesterol. It form cholesterol and hydrogen peroxide. And these hydrogen peroxide react with all these phenols of oxidation, 4 amino antipyrine, it form quinonamine complex. Okay, so this is the principle, and after the reaction you will write it. Absorbance of quinonamine measured at 505 nanometer. Absorbance of quinonamine, it is not amine, it is I. Quinonamine. The table here, you will make the table very carefully. Write it first heading, serum or plasma. Serum or plasma. So put 10 microliter in test tube T and rest one is blank. 10 microliter in test tube T. Okay. Now cholesterol standard. Ten microliter in test tube standard. 10 microliter in test tube standard. दिखा जरा क्या लिखा. Yes. Not distilled water. Why you write distilled water here? Cholesterol standard. Okay. What you write? T 10 microliter. Okay. Now write in also in blank. We take directly cholesterol reagent. Cholesterol reagent. Cholesterol reagent. It is 10 microliter in, yes, blank. And finally add cholesterol, working cholesterol reagent. Working cholesterol reagent. ब्रैकेट में डालेंगे किट बेस. वर्किंग कोलेस्ट्रॉल रिएजेंट ब्रैकेट में किट बेस. किट बेस मतलब किट में जो निकलेगा रिएजेंट उस रिएजेंट को ऐड करेंगे. ओके. Added 1000 microliter in each test tube. 1000 microliter in each test tube. नीचे लिखेंगे mix well and incubate for 37 degrees Celsius. Sorry, mix well and incubate at 37 degrees Celsius for 10 minutes. ओके 10 मिनट्स के लिए हम उसको छोड़ देंगे. उसके बाद वही सीधे कैलकुलेशन लिखिए. बिकॉज you don't perform this test, so I directly mention calculation here. Cholesterol concentration, it is mg per dl. Cholesterol concentration mg per dl is equals to cholesterol concentration in mg per dl is equals to absorbance of test upon absorbance of standard. Absorbance of test upon absorbance of standard minus absorbance of blank multiply by 200. It is concentration of cholesterol in mg per dl is equals to absorbance of test upon absorbance of standard minus absorbance of blank multiply by 200. So we directly put either absorbance of test, absorbance of standard multiply by 200. The value given in which unit comes? mg per dl. Okay, mg per dl. If we want to convert the value of mg per dl cholesterol in millimole per liter, don't talk. If you have any queries, you will ask to me. Don't talk. Millimole per liter, then multiply the value of cholesterol in mg per dl into 0.0259. This is like that 259. Yes, 0.0259. If we directly multiply the value through this factor 0.0259, then the value which is comes will be count in millimole per liter. Millimole per liter. Okay, so this is our calculation to calculate the cholesterol value. Okay, now write the clinical interpretation CI. Clinical interpretation. You already know the normal range. It is 150 to 200 mg per dl, but in some of the books its value is more comes. It is up to 250 mg per dl, but we consider only 200 mg per dl. Okay. On the basis of the range, we classify the range about 2 factor. The first one is hypercholesterolemia. Okay, the causes you already know. It is in nephrotic syndrome, in the case of diabetes mellitus, in the case of diabetes mellitus, and also write it some of the cases. In the case of obstructive jaundice, your jaundice portion is over in the class? Huh? Your jaundice topic is discussed in the theory class or in even also in SGD? Who will discuss? ये पता है कि डिस्कस हुआ है, पर ये नहीं पता कि किसने डिस्कस किया। बायोकेमिस्ट्री में किसने? ओके ओके, अगर डिस्कस नहीं हुआ है तो अगली क्लास में मैं कर दूंगा, चिंता, यू डोंट वरी अबाउट दैट, वी डिस्कस. Either physiology teacher will discuss about the jaundice, as a biochemistry teacher is also discussing jaundice. That doesn't matter. You know about the jaundice, that is important. Okay? Obstructive jaundice. In the case of obstructive jaundice, cholesterol level is high, and there is one enzyme, SGPT is also high. Okay? In hypothyroidism, also write fourth disease, hypothyroidism. So these are main clinical disease in which hypercholesterolemia is seen and decreased level of cholesterol. In which disease? First one is, where is the fate of the cholesterol occur? Where the cholesterol metabolize? Where the catabolism of the cholesterol occur? Yes. So definitely if the liver is not functioning well, the cholesterol level become low. So it is in the case of liver damage. I will mention here damage. There is so many cases, all the cases are considered. If I will talk about liver cirrhosis, it is fibrosis of the hepatocytes, and it is mainly concerned with the alcohol and drug abuse or either non-alcoholic fatty liver disease. Okay, so I will mention here damage. It will consider all types of liver hepatitis. Second one, in the case of hyperthyroidism, write it hyperthyroidism. Hyperthyroidism. And in Tengious disease, also in chronic anemia, So all this, in all the disease, the level of the cholesterol is we found low. Okay. So this is the clinical interpretation of our laboratory cholesterol estimation. But there is some measuring criteria, or we talk about some factor which can give the false values also. So for the estimation, you will make heading note, नोट डाल के एक पॉइंट लिखेंगे, उसमें लिखेंगे we don't use hemolyzed, ecteric, or lipemic sample for cholesterol estimation. We don't use hemolyzed, ecteric, or lipemic sample for estimation of cholesterol. This can give false value of cholesterol. This can give false value of cholesterol. This can give false value of cholesterol. Now students, understand what I say from this. Hemolyzed means because it is quantitative estimation of the cholesterol, and this quantitative estimation is depend on what? Major principle for the estimation of Curl-Limit method. Which is the principle of Curl-Limit method? You tell the name of the principle. Don't know? पढ़ लो बेटा, पढ़ लो थोड़ा सा, अभी रीजन नहीं चलेगा ना, एक्सक्यूज चलेगा. It is Lambert's-Beer law. Lambert's-Beer law, you already know that it says that the concentration of any metabolite depend on the intensity of the color. Okay, so intensity of the color, if we use hemolyzed blood sample, hemolyzed plasma sample, then there is already the color of RBCs. Okay, if we add more this reagent, what happen? The intensity of the color is more. So ultimately what we get? We get wrong values. Okay, we get wrong values, not a high amount, we get wrong value directly, because hemolyzed, which color is present here? Red in hemolyzed sample. Ecteric or ecterous means it is a type sample of jaundice. Okay, it is highly yellow color, dark yellow color we obtain such kind of sample. Lipemic sample, white color. Okay, white fumes like appearance are seen in such kind of samples. So all the sample which we collected from such kind of disease for estimation to the colorimeter, we directly not taking the sample from that. If we take the sample, we take proper methods. Otherwise, what we get? We get false values. Okay, so these all are about your cholesterol estimation, and we are not further performing this test in the lab. But if question is asking in your exam, just like that in also in practical exam, write the method of cholesterol estimation. Then you will write all these things which I will dictate you. Okay. Complete also write this all this matter in your final copy. उसी तरीके से चेक कराएंगे इस कॉपी को, जैसे पहले और सिलेबस में चेक कराया है, इसको कंप्लीट करेंगे. ठीक है. अगर मैं आपको कोई वैल्यू दे दूं, somebody I will tell you it is value of the cholesterol is 360, then what would you assume? Okay, what is the risk factor of this hypercholesterolemia? What happen if there persist 360 cholesterol is present in the person? What kind of disease? What is the risk factor? It is directly risk factor of CHD, coronary heart disease. In the coronary heart disease, there is all the diseases are concerned, like myocardial infarction are concerned, atherosclerosis are concerned, chances of heart attacks are concerned. So you tell only a one name, that person having a chances of CHD, coronary heart disease. Okay.
Atypical are C1. Atypical are C1 is also known as Atlas. C1, that is also known as Atlas. Okay. C2 is also known as Axis. C2 is also known as Axis. Okay, and C7 C7 is also known as vertebra prominence. C7 is also known as vertebra prominence. So these are the atypical cervical vertebra. Okay. Now write it down. Two identifying feature for cervical vertebra. Two identifying feature for cervical vertebra. So what are those? Number one is foramen transversorium. Number one is foramen transversorium. So what does it transmit? In bracket you write vertebral artery, vertebral vein, and another one is sympathetic chain. Okay, so these three things would be transmitted by this foramen transversorium. So throughout foramen transversorium will transmit three structures. They are vertebral artery, vertebral vein, and sympathetic chain. Okay. So in which vertebra this foramen transversorium is absent? Atlas e ache, have you seen? So which one is the atlas? This is the atlas. How to identify? It has got no body and no spine. Okay, it has got no body and no spine. And how does it look? It is looking like a ring. Okay, and you could see in the transverse process there is presence of foramen transversorium. Okay, for axis also that is there. Okay, so where it is absent, write it down. In some cases at C7, in some cases, সব সময় হয় না, okay, in some cases in C7 there is absence of foramen transversorium. Okay, and remember, in case of C7 it will only transmit, write it down, in case এটা MCQ তে আছে, in case of C7 foramen transversorium will only transmit the accessory vertebral vein. Okay, so this is all about foramen transversorium. Next thing is, what is the next identifying feature? Accessory vertebral vein. Okay, what are the other triangular feature? Not about atlas axis. I am asking cervical vertebra as a whole. Triangular key. The vertebral foramina is triangular in shape. This is also another feature. Okay, the vertebral foramina is triangular in shape. Okay, and the third point is, এখনো মেন ইম্পর্টেন্ট পয়েন্টটা কেউ বলেনি, what is this? Spine is bifid. Okay, so the third important features are, write it down, the spine is bifid, or it is also known as bifid spine. Okay, so these are the identifying feature for the cervical vertebra. Now we will gradually discuss one by one. Number one is atlas. Write it down, atlas or C1. Spine, bifid spine. Okay, so write down the feature about the atlas. Okay, atlas or C1. So why it is called atlas? Why it is called the atlas? So this is the atlas. How to identify which one is the superior surface, which one is the inferior surface? See here, this is the fossa. This is also known as superior articular facet. This is for occipital condyle. Okay, and I told you it has got no body and no spine. So these are the identifying feature. And additionally, in inferior side again there is another bean shape or kidney shape articular facet, that is for axis, okay, or the second cervical vertebra. Now write it down for atlas. Characteristic features are, this is called atlas. According to the Greek mythology, it is taking the weight of the skull. It is taking the weight of the skull. Okay, so see here, this is the, এটাকে কি বলে, occipital condyle. This is which bone? Occipital bone, and these are the occipital condyle. So this superior articular facet, it will have joint over here, okay, so that the whole weight would be transmitted by this atlas, okay. So that's why it is very much important. Second one is, it has got no body. Write it down, it has got no body. Then third, it has got no spine. It has got no spine. Okay. Then how the vertebral foramen has look like? It is circular. Okay, circular and large and circular vertebral foramen. Large and circular vertebral foramen. Okay, superiorly, write it down, superiorly has superior articular facet. Superiorly has superior articulate facet, which will join the occipital condyle, and forming কি জয়েন্ট তৈরি হচ্ছে এটা? এটা পিভট. What is the joint? Name of the joint is atlanto-occipital joint. Write it down. It is making atlanto-occipital joint. Okay. And it is a plain type of synovial joint, or you could say condylar joint. Okay. Which movement is taking place? ওটা নয়, কোনটা? ফার্স্ট ক্লাসে বলেছিলাম জেনারেল অ্যানাটমি, কি কোন মুভমেন্টটা? Yes, it is nodding of your head. Okay, so that is atlanto-occipital joint. Okay, atlanto-occipital joint. Then write down, inferiorly has bean-shaped articular facet. Bean-shaped articular facet. See, this is which vertebra? It has got these tooth-like projections. So this is the odontoid process of axis. Okay. So where it will articulate? It will articulate just below to the atlas. Okay. So it is known as, what it is? Known as atlanto-axial joint. Write it down. So inferiorly have bean-shaped articular facet. You could see this is a bean-shaped articular facet, okay, which will join with axis. এবার এই জয়েন্টটা কতগুলো থাকে? How many are there? কটা থাকে? See, one is this one, this ring of atlas with the odontoid process. This is known as median atlanto-axial joint. Okay, and another are these two. These are the condylar joint. Okay, it is making this one. So these are the lateral atlantoaxial joint. Okay, so write it down. Number 1 is median atlantoaxial joint is made by, this is the anterior arch of atlas and with the odontoid process. This is the odontoid process. Okay, so it would be like this. Okay, so the median atlantoaxial joint is formed by the anterior arch of atlas with the odontoid process of axis. Okay, and which type of joint it is? It is a plain type of synovial joint because no other movement, slide movement. Okay, and the two lateral atlantoaxial joint is a type of, which movement is occurring? Yes is over for the atlanto-occipital. No. Okay. Understood? So this movement, no is happening. See, this side it is moving, both sides. Okay. So this no is done by atlantoaxial joint, lateral atlantoaxial joint. So you could write no quotation, no movement has been done by lateral atlantoaxial joint, and it is a type of, এটা তো বলা উচিত, which type of joint it is? হ্যাঁ, সবকটা প্লেন হলে কি করে হবে? এটা কি? নো মুভমেন্ট টাই কি হচ্ছে এটা? It is what you could see. No. Pivot joint. It is a type of pivot joint. Okay. সবকটা বলে দিলে এটাই বললি না। So we could see এখানে কোনটা রিংটা ফিক্স থাকে। রিং হচ্ছে এই odontoid process. Okay. But this axis is moving. Axis কোনটা এই arch of the atlas. It is moving. Okay. So it is a type of pivot joint. Okay. Now about the atlas, we will see what are the features, bony features, and what are the attachment. That is very much important. Okay. So see in this picture, first one, what are the feature you will get? So first one, this one is this spine. This is known as anterior tubercle. Okay. And backwards you could see where this spine is become, that is the posterior tubercle. Now write it down. What are attached over here? Anterior tubercle. Which thing is attached? That is anterior longitudinal ligament. Okay, anterior tubercle for anterior longitudinal ligament. Okay, then posterior tubercle. কেউ বলতে পারবে posterior tubercle এ কি attach থাকতে পারে? কমন স্ট্রাকচার যেটা স্পাইনে থাকে। একটা লিগামেন্ট থ্রু আউট গিয়ে এইখানে অক্সিপিটাল যেটা প্রোট্রুবারেন্স, এটা এক্সটার্নাল অক্সিপিটাল প্রোট্রুবারেন্সে গিয়ে একটা লিগামেন্ট গিয়ে এখানে ইনসার্ট হয়। হোয়াট ইট ইজ কল্ড? থ্রু আউট স্পাইনে যাবে, দ্যাট ইজ নোন অ্যাজ লিগামেন্টাম নিউকি। ওকে, লিগামেন্টাম নিউকি। ওকে, সো পোস্টেরিয়র টিউবাকল, see this is the spelling. Okay, ligamentum nuchae, nuchae, posterior tubercle. Understood? It will go throughout the spine. Okay, and where it would be attached, see, you could also feel your external occipital protuberance. Just touch your head, you could also see the bony prominence on the posterior side. Okay, so that is known as external occipital protuberance. Okay, it will be inserted over there. Okay, so that is about the posterior tubercle. Then what are the other attachment you could see? On the side, see, so many muscles are attached. So many muscles are attached. At first we will see on the side. So So vertebra are present on the back of the neck, right? So what are the muscles? Back of the neck e ki muscle thake? Inside. You are saying the posterior part of the neck, anterior part of neck. Longus colli. Okay. Number 1, write it down. Anterior arch e ki muscle thakbe? Number 1 is longus colli. You could see this is the longus colli. Okay. Then the next muscle is rectus capitis anterior. Rectus capitis anterior. Okay. So these two muscles you have to say longus colli and rectus capitis anterior. Keep on the anterior arch. On the anterior arch. First is thakbe longus colli, then thakbe rectus capitis anterior. Okay. Then coming to the transverse process. See the transverse process. This is the transverse process. So it has got 3 muscular attachment. Okay. Write down. On the transverse process. On the transverse process, there are 3 muscular attachment. Okay. Number 1 is rectus capitis lateralis. Number 1 is rectus. See here, this is the rectus capitis lateralis. Okay. So at the spine, there is one muscle of the eye that is known as inferior oblique. Okay, inferior oblique. So just think about that, from eyeball it is coming to the atlas. Okay. So inferior oblique, and the last of the spine there is levator scapulae. So write it down. The examiner may ask you on Viva what are the muscles from anterior to posterior. Number 1 is rectus capitis lateralis. Then at the spine is inferior oblique, and this side is levator scapulae. Okay, write down. There are 3 muscles. Okay. So on the inside of the transverse process, there is another muscle that is known as superior oblique. Okay. Inside of the transverse process, see here, just beside the foramen transversorium, that is superior oblique. Okay. And on this side, posterior arch, only one muscle, that is rectus capitis posterior minor. Rectus capitis posterior minor. Write it down. On the posterior arch. Head, brain, neck is too much complicated. Okay, you could see one muscle name is rectus capitis posterior minor, and another muscle on the face is known as levator labii superiorlis allicinae. Levator labii superiorlis allicinae. এখানে থাকে. On the bend of nose, you are having that. Superioris allicinae. Allicinae. So consists of 5 words. Okay. Okay. So this is another muscle that is known as rectus capitis posterior minor. Okay. So write it down. There are 2 membranes. एकटाई muscle. हो गया? Okay, keep quiet. So there are another 2 membrane. Write it down. There are another 2 membrane that is known as, this one that is known as anterior longitudinal anterior atlantoaxial membrane, and this one is posterior atlanto-occipital membrane. Write it down. There are 2 membrane, 2 additional membrane. Okay, on the anterior arch and posterior arch. It is called the anterior atlanto-occipital membrane, and posteriorly posterior atlanto-occipital membrane. There are 2 membrane. Okay. Now see what are the vessels and nerve we will have on this atlas. Okay. So there is only one nerve. কোন nerve হতে পারে atlas এর উপরে? that is cervical one, C1. Okay, so see where the C1 would be situated. On the, it is crossing the foramen transversorium. Okay, so between the transverse process and the superior articular facet, there is first cervical nerve. Okay, and additionally there is one membrane that is also known as oblique ligament, and one vessels on the lateral side that is known as, which artery it is? Vertebral artery. Now which part of the vertebral artery? Third part of vertebral artery. Now could you tell me what is the blood supply of brain? Last supply of brain. You have already completed the thorax. Have you studied deep cervical fossa? Carotid sheath. Carotid sheath হয়েছে? So general idea is there is common carotid artery, right? You know common carotid artery is coming from where? Arch of aorta, right? From that it is taking two artery, it is bifurcating into two. One is external carotid, internal carotid. External carotid would be giving to the face and neck, head, this area, and internal carotid artery would be giving to the brain. Okay, so which is the other artery that would be supplying the brain? That is the vertebral artery. Understood? So brain would be supplied by internal carotid artery and vertebral artery. So these vertebral artery definitely it will go above the atlas. Okay. So which part that is? That is the third part of vertebral artery. So write it down. What are the vessels? Vessels present above the atlas are number one is first cervical nerve. Okay. First cervical nerve. Vessels and nerve, actually that would be structure. Structure above the atlas. Structure above the atlas, number one is first cervical nerve or C1. Okay. And the vessel is third part of vertebral artery. Third part of vertebral artery. You could see this artery is going. Okay. That is the third part of vertebral artery. Okay. And there is one ligament, write it down, oblique ligament. There is another ligament that is known as oblique ligament. Okay. So that is all about the atlas. Okay. Now we will shift to the axis. So write it down. It is also known as atypical gulo is very important. Okay. So axis are, number one is, it has got, what are the part of axis? How does it look like? See, it is looking like this. Okay. So how to identify? You could say there is one tooth-like projection. So that is known as dens. It is also known as odontoid process. Okay. So write it down. The axis has got tooth-like projection on the superior surface. Tooth-like projection on the superior surface. It is also known as, I will break the chain. इसीलिए कोविड अच्छा था नहीं? So it is also known as odontoid process or dens. It is also known as odontoid process or the dens. Okay, dens. What? Odontoid process. Okay, or dens. This one on the superior surface. What are the additional thing you could see? There is two oval articular facet for the atlas. Okay, on the superior surface. So write it down. On the superior surface, there is two oval superior articular facet for the atlas. Okay. Now, what are the bony feature you could see? See the transverse process. It is small, right? And it has got this foramen transversorium, right? Now if you see the spine, okay, it is somewhat elongated and you could see it is bifid. So this is very important. So it has got bifid spine. Atlas has got no spine, okay, but in axis you are having bifid spine. Okay. Okay. And see, on the inferior surface also has got only one circular articular facet that would be articulating to the C3. Okay. So on the inferior surface there is only one articular facet for the articulation of C3. Okay. Now these axis and atlas are very much important. Why? Because at this area you know which structure it transmits. What is this? ये क्या है? This is the foramen magnum. Okay, what does it transmit? The spinal cord. Okay, so and you know this spinal cord there is a presence of cardiorespiratory center, right? So if the atlas and axis are there and if the odontoid process is having superiorly, so this part how it is in the same place, why there is one ligament that is known as transverse cervical ligament. Write it down. The atlas, the ring of atlas, the ring of atlas and the dens of axis. The ring of atlas and the dens of axis are fixed in place by so this ligament is very much important. See here, this is the transverse ligament of atlas. You could also see on the ring. Okay, this ligament it is making this thing on the place. Anyhow, if it is torn, okay, যদি এটা কোনোভাবে torn হয় তাহলে কি হবে? This odontoid process it would be pierce the medulla. Okay, cardiorespiratory center. এবং এটা কখন হয়? Very good. It is occurring in hanging. Okay, maybe it is occurring also in the suicide. The same phenomena. How the death is occurring. Understood? This odontoid process it would be pierced. This transverse ligament should be torn. So that this odontoid process it would be accidentally pierce the cardiorespiratory center of medulla and it is causing the death of individual. Okay. So you could also write in case of hanging or suicide, the transverse ligament of atlas. In case of hanging or suicide, okay, in case of hanging or suicide, the transverse ligament of atlas get accidentally torn up, okay, get accidentally torn up and it is causing death of, you could also write piercing the cardiorespiratory center of medulla oblongata, piercing the cardiorespiratory center of medulla oblongata and causing the death of individual. ये अच्छा से लिखा है जो रेड्डी का बुक है FSM. Okay, you could collect from your senior. Okay, in that you could get this thing. Okay. रेड्डी KM रेड्डी करके वो I think South Indian author for forensic medicine. Hanging টাই তো এখানে transverse ligament এ থাকে. Okay, if it is anyhow teared up, what will happen? This odontoid process would be pierce the cardiorespiratory center. Okay, and then it will cause death. Okay, so this is the medico-legal importance of the odontoid process and the atlas. Okay, so write it down. Attachment of axis. The attachment of axis. Okay, At first, see, be quiet everyone. See what are the attachment? Number one is on the apex, on the apex. On the apex there is attachment of apical ligament. Be quiet. On the apex there is attachment of apical ligament. Okay. So you could see here the first attachment over here is the apical ligament. Okay. So on the side there is the attachment of, on the both sides there is the attachment of alar ligament. Alar ligament. Spelling A-L-A-R. A-L-A-R. Okay. Alar ligament. What I said? On the apex it has got apical ligament, on the side it has got alar ligament. Okay. Now what are the other attachment? You know, on the at the neck it has got transverse ligament of atlas. Okay. Write it down. On the neck it has got this transverse ligament of atlas. Okay. Then on this side here there are three type of things that will transmit along with the spinal cord. What are they? So C is sincere, okay. But why you are asking? Write it down. Number one is, so one by one you write. Number one is cruciform ligament. Number one is cruciform ligament. Then second one is membrana tectoria. Second one is membrana tectoria. Okay. And the third one is posterior longitudinal ligament. তুই বলবি, ও উঠে বল। So number one is cruciform ligament. Just like knee joint you got, right? Anterior cruciate and posterior cruciate. Here cruciform. Okay. Then membrana tectoria. Membrana tectoria, and the third part is posterior longitudinal ligament. Okay. Posterior longitudinal ligament. Now what are the muscle? There is only two muscle you have to know. One is scalenus medius, write it down, scalenus medius. And another one is levator scapulae. Levator scapulae. Levator scapulae actually প্রতিটা vertebrae কোথায় থাকবে? At the tip of transverse process. Okay, at the tip of transverse process. Both sides. Okay. And on the spine there is deep muscle of neck. There is deep muscle of neck. What are they? Trapezius, rhomboideus, minor. These two you have to mention. Trapezius, that is my anterior. It is also known as subcutaneous muscle. Only one muscle which is subcutaneous. Okay. It is present on the anterior surface of neck. Subcutaneous. Fasar upore thake, but only one muscle subcutaneous, that is platysma. Okay. So deep muscle of neck ki bollam, ekta hocche trapezius, then another one is rhomboideus minor. Okay. So these two muscle would be there. Okay. And see on the bifid, it has got the bifid spine, right? So in between the spine there is one ligament that is known as ligamentum nuchae. Okay. So in between the spine there is ligamentum nuchae. In between the spine there is ligamentum nuchae. Okay. Now would be coming to the last one, that is vertebra prominence or the 7 cervical vertebra. Okay. So see, they have given this is the 7 cervical vertebra. How to identify this one? See, it has got any transverse process, means foramen transversorium it has got. These are the transverse process. I told you in some cases it is absent, right? And see the spine, it is very elongated and long. Okay, long, slender and elongated. So write it down. Bolchi. Okay, write it down. He raised one very important question. What is the difference between the thoracic vertebra and the C7? How to differentiate? Okay. Now you have to go for the other feature. See the body. How does it look like? It is triangular, right? And you could see there is no presence of costal facet. This is the important thing. You have to take the point from the thoracic vertebra. Thoracic vertebra costal facet থাকবে, but here you won't get any costal facet. Okay. So now write it down. What are the features of the 7 cervical vertebra? Are number 1, the body is triangular in shape. The body is triangular in shape, and the vertebral foramen is circular in shape. It has absence of foramen transversorium. Absence of foramen transversorium. Okay, and long, slender and elongated spinous process, or you could say longest. Okay, longest, slender and elongated spinous process. That's why it is also called vertebra prominence. It is also called vertebra prominence. Okay, another thing you will get, here is one important thing that is also known as costo-transverse bar. Okay, this one is also known as, this transverse process is also known as costo-transverse bar. So see there, it is making one triangular area beside, so that is known as costo-transverse bar, this one on the side. Okay. Now who will tell me the attachment of this transverse process and the superior articular process of the C7? Transverse process, this thing you must say. Cervical pleura or Simpson fossa, understood? It is coming from the first rib, okay, and it is going to the C7, okay. So write it down. Attachment of cervical pleura or suprapleural membrane, or another one is Simpson's fossa. On the tip of transverse process, of C7. Okay. Okay. And another important thing is that, see, every spine there is one ligament that is known as ligamentum nuclei, right? But in between the vertebra, on the inferior surface, there is another ligament that is known as ligamentum flava. Okay. The inferior surface between the cervical vertebra, there is presence of ligamentum flava, FLAVA. Ligamentum flava. Position in between the cervical vertebra, inferior surface. Okay, inferior surface in between the cervical vertebra, there is a presence of ligamentum flava. Okay, so So these are the feature for the 3 atypical cervical vertebra, and the characteristic feature already I have discussed. Okay, and you know on the spine there is another 2 muscle. This side there is erector spinae and multifidus. Okay, these are the muscle you will get on the spine, just like the thoracic vertebra. Okay, so have you got this specimen with you? Cervical vertebra আছে? নেই তো? So, আজকে জানতিস ক্লাস হবে? তোর কথা বাদ দে, বাকিদের? Every cervical vertebra, okay? At least identify these 3, atlas axis and the C7. Okay, you could also see from here. দেখতে পারিস এখানে